Yeah. So hello everyone. Hope you all have having a wonderful day. Today we're going to have a small session, or rather than a session, it will be a discussion on communication in parenting. So I'll just share my screen. So hope everyone can see the share screen. So this is our today's topic, communication in parenting. So am I clearly audible? Yeah, okay. Thank you.
Yes.
So we're just going into the session. Okay. So what basically communication means? Can anyone say what is communication? In a few words. Can anyone say that? Okay, don't hesitate. Okay. You can just freely talk with me during the session. If you have any doubts or anything, you can just chat me in the chat box. Okay.
Information exchanged between the sender and receiver, and it can be done verbally or non-verbally.
Yeah, thank you, Rashmi. Actually, it's a correct answer. So it's about everything is all about information. So the sharing of information is what we call as communication. So that's a basic process, and how it can be converted into communication, that communication into palliative care. So that's what we are going to discuss today. So we have some objectives. So we'll be just going through that. So the objectives of this session will be what is communication, need of communication, positive body languages, barriers to effective communication, steps to effective communication, good versus poor communication, and lastly, what is listening. So these are the factors, or these are the facts we'll be going through this session, and hope at the end of the session you all will be very familiarized with all these terms. Okay, so starting with communication. So what is it? As Rashmi said, it is the information sharing. You can see in this picture, it's a conversation between two persons. So the first one is saying, your food smells delicious. That is the message, actually. So she's the sender, and the second person who's sitting beside that lady is replying that thanks. And with that feedback, he interprets the meaning, like she wants to try a bite. So this is where communication, like it comes into like communication. It is the process of sending and receiving messages through verbal or non-verbal means. The verbal thing is the food is delicious, means it smells delicious, and the non-verbal thing is he can know about what she wants to say and what is next move. So these all kind of things can be interpreted with a good communication. So this is the basic thing. There will be a sender and there will be a receiver. So the communication between them, or sharing between them, will be the information. So that's a basic thing. Okay. Communication in palliative care. So we all know that palliative care is a vast area. There will be so much things going around in palliative care, because we need a proper communication with the so-called patient. We don't usually refer them as patients. We will say them as beneficiaries or the person and the palliative care team. So what happens is the patient or the person is having so much uncertainty, fear, anguish, and they'll be having so much concern about their disease or their situation, current situation. So what palliative care team does is to clarify that issues and acknowledge the suffering. And we have to think very empathetically. So that's what needed in most cases. So this is where communication in palliative care is important, because when a person arrives at your setting or comes to you, you have to just listen to him, listen to that person. Then only we can just go to next stages, like how this can be dealt with, how an intervention should be done, or what will be the plan for the next few days or few months. So these all things can be done with an effective communication. So communication is palliative care is very important. So this is the basic thing in palliative care. So why communication is important for patients? So we will talk about the communication in the perspective of patients first, or the persons first. So as the point suggests, it helps to express his or her needs or concern. We know that every person is having so much problems. If you consider yourself as a patient, when you're going through a small fever or anything, and you will be having a severe headache, so that's your concern. So if it will be cured, or should I take any medicine, or should I just go to a doctor? So there are a lot of concerns that comes around. So these things can be expressed to a doctor or a palliative care physician with the help of a good communication. So this is the first thing for a patient in the area of communication. So the second one will be permit ventilation of feelings, because in every cases, in every person, they will be feeling like does the doctor exactly knows what happens with me, or how I feel now. So these kind of things comes to a person's mind very frequently. So that ventilation of feelings can be done with the help of a good communication. Then it helps to clarify doubts and baseless apprehensions. What happens is, if a person is having a severe stomach pain, maybe it should be in the form of any other diagnosis, but he will be having, or he or she will be having the thought like, is it cancer, or is it a deadly disease or something? So there will be so much doubts in their mind. So this helps to clarify that very in a shorter period. So next will be give assurance, reassurance, and realistic hope. So they will get that reassurance and that realistic hope that it's not a concern of that kind of disease, or this is because of that. So this kind of feeling gets into that. So next one will be give the patient and family a sense of direction. So there will be a dilemma like how can this be done, or for whom, or means where should I go? So there's a directionless period in everyone's life when you consider the patient. So with a proper communication with the period, like palliative care physician, it will be a great direction for them. Like you can go through this and you can go through that. So they can guide you properly. So sense of direction is given to the family and the patient too. Then next will be help or guide them in decision making, because so much persons are not into taking decisions in their situation, because they are not concerned about the diagnosis at first. They'll be concerned about their family and family members. They will be thinking about the future things that is going to happen. So there will be so much stress factors that is going around their life. So a proper communication leads them to decision making process, because this is going to happen, so I have to be like that. So this is the decision I have to take. So we don't intervene in their decisions. We will make them feel that this is best for you, or this is what happening. So you have to take care of this, and you have to take care of this. So then they will be coming into a process where they will be taking their own decisions by their own. So next will be assisting for coping with bad news. Um, when you consider, as previously said, I'm a pediatric social worker. So I work in SAT, means medical college. So there we have an OP. It's not a regular one, it's in Thursday. So there I see a lot of kids and their parents. So what happens is, when you consider adult citizens, if they are getting treatment for any life-limiting illness, they will be like, okay, this is their age. Okay, so we can accept that. It's going to happen. There will be a bad news. So there will be an acceptance in them. But in some cases, like in the early ages, like in adult stage or in the childhood, in the case of pediatric kids, the coping with the bad news is very rarely seen, because there'll not be. Today also, I want to just give you a small example. Like today, we just registered a patient. Yeah. So the daughter was a patient. She was very energetic towards her eighth birthday. So now she is 9 years old, and after the eighth birthday, she started to get fevers, frequent fevers, and now before 2 or 3 weeks, she was diagnosed with CP, because she's having severe seizures and lot of episodes of like mm, pain and all the things, and she was admitted in SAD, and now she got registered here. And her father is a person who is a fully by profession and who came to register. And what was his idea is that I can handle this. I don't want to reveal this to my family members. My wife just only knows about the situation only. Her current situation, I don't want to express this to her. I will manage. So in this case, the father is very stressed out because he knows what is exactly happening, and he doesn't want to share it with others because they will feel very bad about the kid, and so much is happening right now. So what we did is today, we had a small session with him, and first registration procedure was completed. Then a doctor talked with them, and after that, a social worker is intervened, and we get a help from the psychologist who is actually in here now. So what happened with that session is uh, he just accepts, yes, this is going to happen. So this is the stage now. So just hiding all the things with the family just won't take it won't solve all the problems. We have to get the support of the family too. But it's not possible to cope with this with only one session. It will be CP means cerebral palsy. Okay, so it will be like yeah. So they will be in a dilemma because that person is in a big dilemma. Like how can I cope up? And so many things are going on. So with the help of that psychologist, what we did is we just had a session. So we just completed it, and we will be going through several sessions. And we just informed him that he can just bring his wife on another day. So then we'll be having a session with them, and we'll be exploring more about the disease and the family conditions of them. So then we can just get a clear idea about what they know about that illness, and then we can intervene. I won't say that it will be very easy. It is very difficult. But what is important is the communication between the whole team, because at the very first stage, a social officer did the registration. The person communicated everything with the doctor. Then the doctor came in and the doctor intervened. And then the information is communicated to the other person, the psychologist. Then there is a clear idea what is happening exactly. So there will be like they all know that this is what is happening, and what should we do, or what can be done on the next later stages. So there will be a so this is an important part, like assisting for coping with bad news. So so these all are the things when we consider the patients. So communication is important for patients. So this is the reason. Okay. Um, so moving on to next one is for like palliative care physicians or for volunteers or for social workers, nurses, doctors. For us, what means a good communication? A good relationship means less stress. Means we can inform them the needed things with a good relationship. If the person doesn't talk too much, or if the person and doesn't know anything about you, then you can't just give all the information. So there will be a lot of stress for us because we don't know what the person exactly thinks or what he's going through. So a good relationship means there will be less stress for us. Then better understand the impact of illness on quality of life. Um, when we talk about quality of life in palliative care in Pallium India, we focus on improving how to improve the quality of life of the patient and the family. So that is the baseline of Pallium India. It is not by the means of physical, it is in the means of physical, psychological, social, and emotional, and also in the spiritual way. So better understand the impact of illness on quality of life. That illness will be will make a huge impact in their quality of, not in the patient's life. The patient is also a part of the family, so the whole family will be affected. So we have to consider all of that. So this is an important fact. Next one will be understand patient's thought process. This is not a simple step. This will take a huge step, and this will take a several cycles. Then only we can think about what the patient is going through, and we can just intervene. Then helps to build trust. A good communication helps to build the trust. With a good trust, we can just have more. We can gather more of the information, and we can get into more plans. Okay. Then next one will be understand patient beliefs, values, concerns, and priorities. Because everyone is each individual is unique. So they will be having so much beliefs and values and concerns and priorities for them. So we have to consider all of these things in the coming stages. Next one will be provide required information on diagnosis and prognosis. I mean, diagnosis means what is the medical term, like if it is cancer, then that is called a diagnosis. Then prognosis means what will happen in the later stages. So that is called prognosis. Okay. Provide required information on diagnosis and because in some cases you will not be able to give proper information about them. Just only give them the required information on this, because if the person is very stable and he's having a good healthy relationship with the family, so we can just take the consent with them, or we can just ask them, what do you know about the diagnosis? What do you know about prognosis? How far, how long have been you are into this, and what do you know about the illness now? So with collecting that information, we can just give them the exact details. Only the required information should be given. Next one will be better better compliance with management, because there will be physical management and psychosocial things are there. So overall management should be done very neatly. So this will be the useful thing for us in communication, the help of communication. I know it's going very raw because the subject is very raw. We'll be having some examples and some real life scenarios. So you can go through that, and I'll just give you a small example of a story. With the help of that, just go into that story. then we can relate this whole communication. Okay. So the story is about a small kid who was registered in pediatric palliative care. So the kid is now 1 year and 3 months old. So the baby is having a Menkes syndrome. That means it's a rare disease that insufficiency of copper is the main problem with that. So this baby is now in semi ICU, and his father is a lorry driver. His mother is a housewife, like homemaker, and they are living with the fathers, means the kids' fathers now, and there are the patient, like grandmother and grandfather is there. So this is the family dynamics, and now the kid is in semi ICU. So now, what doctors suggesting is there is nothing can be done. We can go with the support of oxygen concentrator, and the kid's situation is deteriorating in day by day. But there will be no hope. That is what the SAT doctors are suggesting. And at the same time, the mother is not ready to accept that. And father says, you can just put him in the ventilator. So then the life can be extended a bit more. But mother is not willing to, because she doesn't want to give the pain to the kid, because she doesn't want to just intervention from some other persons, because she want to take care of the kid if he is deteriorating or not. She doesn't want to accept that he is dying. So that's a case. Okay, just get it in your mind and just relate everything that we are going to the next step. Okay. So this is small chart where you can see that in personal communication, 7% spoken words are there, 38% of voice and tone, and 55% body language. When you consider this case where the kid is in the semi-ICU, at the time of registration, she came to us and she was like, she wasn't talking too much. She was guided by another doctor, and she was told like there is a palliative care unit. You can go there and you can register. They will tell you everything, and you can just go there and do it. Okay. So that's what the doctors. She came in and she just sat down there. She was not crying. She doesn't have any emotions. She was sitting very straight and she was answering every questions we asked them here, like the basic details about the kid, the details like family dynamics, everything. But after a while, her body was like giving all the information. She went very down, like her body languages shown some signs that she's not in a good position to talk, and her voice and tone were changing. And after so much time she spent with her, she just broke down. Broke down in the sense she told very emotionally that I don't want to live. My kid is dying, so I don't know what to do next. So that's what happened in that situation. And her body language was like she was shivering, and her eyes were not very intense. Like she wasn't looking at any of us. She was looking somewhere else, and her speech was stuttering. And all of a sudden, the doctor came in and just touched her shoulder and said, "Okay, you can talk to us, no problem." At that time, she just cried a lot, and She expressed her concerns and her past experience with us. And it was so horrifying that her story is, I want to just explain everything to all of you. Her story was very emotional, and she went on to some like domestic violence and that kind of things. And her actual problem was she's not getting the exact support what she wanted from her husband, because he wants to just put the baby in ventilator and he wants to move on. So that was the main thing she was concerned about, because at that time she wanted someone to stand by her. So when talking a lot, we just came into a position where the problem is not with the kid, the problem is with the family, the broken family. So we just assured her like nothing could be done in the case of the kid. He needs that oxygen support, and everything will be going like this. It's not a curable disease. The situation now will change. Why are you stressed out? Your stress factors will be changed when you just come into the admission with us. So after several sessions, what happens right now is she is getting very bold, and now she is into the realm like my baby is going through this. This is what is going to happen. My husband is not very supportive, but okay, I can understand that. But I am the one to take care of my kid, and I am the one who will do it without any hesitation. So she is very strong with her voice. And after that, we just had a session with that like the kid's father, and for our surprise, at the very first time he wasn't very talkative. He doesn't want to reveal anything, but now he is coming into the hospital once a week, and he is giving the support to her. So, like with the proper communication, I just want to mention this story because why? Because with the proper communication, with that intervention, we just made a progress in that case. Now she is going to admit the kid in Pan India. It will be on Saturday or Monday. So they are coming here for that supportive care, the palliative care. So with the proper communication, with the help of that interdisciplinary team, like a doctor, social worker, nurse, and a volunteer, with the help of all of them, we just made a huge difference there. Because what happened in SAD, the government setting, is they have several patients and they don't have enough time to take care of each person. But in our palliative care, what happens is each patient needs equitable care. So some persons need more care, someone needs only a short one. So what we do now is properly, with the proper communication, we just go into a proper plan, and this will help us to do some long-term and short-term goals, and we will plan accordingly, and we will intervene, and we will just execute the things. So this is where the elements of personal communication comes in. Like we can start with that. Like that body language is 55% and 38% voice and tone, and 7% spoken word. Because we have to consider all these things in this process. And next one is the positive body language. Very simple. Like what I am doing is eye contact, making an eye contact with all of you. So then the next one will be the facial expression. Because if I'm very sad, then it will be reflected on my face. But the other person on the other end will not be able to cope up with that. So our facial expression is very important. Next, tone of voice. If a person comes with a very distressed situation, and we will be like very angry at them, like if you're having so much patience in the OP, or if you're having so much registration in the counter, and you will be like, "What's your problem? What's next?" If we talk like that, they will be like, "Oh, this person doesn't want to hear from me. This person is more angry, so I don't want to just communicate with him. I want any other person to talk." So that will be their thinking. So the tone of voice is very important. Then the body position. When a person comes, you will be sitting like without any interest, like this or something. So they will be feeling very bad. Like the person, uh, the person comes with a lot of concerns. So at that situation, he or she wants the other person to be very gentle, and the person to be very keen to them. So body positioning is very important. Then next one will be body posture. Posture of means the leaning forward position will be very good. Then the body space, because everyone needs a space. So we will talk about that later in the session. Then the touch. We'll go through that in the coming. So the first one will be eye contact, like I said before. Making an eye contact is very important, because you don't want to frequently look into the eyes of that person. You just want to just look into the forehead or the nose or any part in the face that you can concentrate, or and also you don't want to stare at them. Okay, so this makes them feel that yes, my conversation is going very fruitfully, and being listened. So this is an important one. Next one will be the facial expression. So we know so much facial expressions are there. So may make an appropriate one. This one is something we need to consider, because when you meet a person at the first time, smile at them. If they are going through a very depressive situation, just consider that person and that situation, and just do it appropriately. You can already know that we are using a mask right now, like in every city. So inside of that mask, everyone can feel that if you're smiling, or if you are very worried, or if you're sad, because with the facial expression, they all can know. So just be gentle to everyone. And next one is tone of voice. Yes, of course. Like how you say it matters. Okay. Like you can say the dialogue like hello in a lot of tone, like hello, and you can say that in hello. Yeah, then you can say hello. So it's like be very gentle with that, and think of that they are the prime person at that situation. So we have to say it very gently. Then body position. Next one. So you can see the two pictures here. Can I say that which one is more appropriate? The first one or the second one?
Second one.
Yeah. Thank you, Rashmi. Actually, in the first one, the patient is leaning forward. It, it doesn't mean that because he's not well, you know that, and the doctor is very gentle, but he's not very comfortable at this moment, because he's leaning forward, and his back portion of his head is not in the pillow, and it's not very good to do it. So because we have to just lean down. And in the second case, you can see that in the pediatric sector, the doctor is like he's having the conversation with the kid very gently and very like entertain fully. That means he is very keen to that kid and he is doing that. It's not a favor. He's doing that like he's into that kid because he wants to communicate very properly. When you just get into that person, then only you can know that what are they doing to and how could we approach them. So we don't have to just stress out them. We just have to be very near to them with respecting their body space also. Okay. And then the next one is body posture. This I don't want to mention about this because we know that the second one is the appropriate one. The first one is a very bizarre one, and next one will be leaning forward. We already talked about it. Like leaning forward is an important thing. Then only they'll feel that you're very much interested into that communication or the conversation. Next one, as I said earlier, respecting body space because everyone has their own space. There will be intimate space, personal space, social space, and public. So when a person comes into our setting, the first one will be there is a public space. Then they'll get into that social thing. Then after several sessions, you only get into that personal space. Then the last space will be intimate, and there will be a big rapport needed to be created for getting into that. If it is needed only, we have to get into that intimate space. Otherwise, you just come into like personal space only because we have to communicate it very clearly about the diagnosis and protocols and everything. So respect the body space. Next one is touch. Here you can see that this is one of our nurses who is doing a home care visit. And in this situation, she's having a gentle touch with that grandmother. So what happens is, I want to tell you one example. Like what I see in the past is, I came from a very rural area where there are several patients are there, like who's having problems with geriatric problems. So there will be a medical camp once in 6 months in our area. So what happens is in a 6 months time, one doctor comes in and he'll be having a medical camp, and the grandparents or that old elder peoples just walk into there, and they'll be having a checkup. And while they were coming back from the place, they'll be telling this doctor wasn't very nice because the older doctor just gently touched my finger, like my body, and he was very gentle, and he's very very care. He gives me very care. So what they were mentioning is a small touch will be efficient than a lot of words because they just want the feeling that you are interested to talk, or you are just very caring about them and you want to talk about their illness and their concerns. So a touch is very important, and at the same time, if they are not interested, you don't have to do that. And we know that this COVID situation, pandemic is going on, and it's not still very decreasing. So just use all the mandatory things and make a touch feel like they are considered. They are getting considered. Okay. So next one is the core principles of communication. So first one will be respect. That means every person is an individual. So there is a unique factor about every person. So respect the other person who is sitting in front of you. And next one will be empathy. A lot of us do there will be sympathy in ourselves, like feeling very sad about the other person. No, you don't have to do that. Just understand the person's feeling, what is happening at their life. If I am in their shoes, then what I'll do, uh, what I'll be going through. Just think of that. Think in that perspective only. So empathy is a very needed principle in communication. Next one will be the trust. Be truthful. I would say that on the first visit, you just have to tell everything, or you just have to just inform them everything. It's not like that. You don't have to use any untrustful words like giving a loose hope will just increase their problems. So just be truthful. Next one will be unconditional positive regard. Don't be judgment. If the person is coming to you and you will be seen the person is very talkative or doing very bad things outside of the hobby or any post or any place, you don't have to be very judgmental because they are in their own space. Now they came to you for another purpose. So don't consider them as this or that. Okay, then consider the patient as the person only. So these are the core principles of communication. Okay. So next one will be barriers to communication. First one will be environmental barriers. The lack of privacy, furniture, noise, distraction, crowded room. What happens is when a patient comes to you, when a person comes to you, if you go into a place, would you rather consider the privacy? Yes, of course, because we are a person, we want to just give the information to them. If there is no privacy, if there are a lot of people are sitting around and you don't have that privacy to talk to them, or you will not just open up. So a lack of privacy is needed, and then the furniture, because the scattered chairs or mm, the not so good furniture at that place or the desk or bench, it will make them feel like this is not a good place to sit or to talk. And next one will be the noise distraction. Because if you're going to, like in this setting, if a person comes to this door and just asks me anything, then that is a noise distraction for me. Then I'll be out of ideas what to talk next. So distraction should be avoided. Then the next one will be crowded room. We need a space to talk to them. So don't take your conversation in a crowded room. Just make a space for them. So these are the environmental barriers. The next one will be barriers related to patients. So when you consider these environmental barriers, the patient will be reluctant to disclose concerns. And as the earlier point, lack of privacy will be there, so they won't open up. Then the fear of confirmation of bad news, because they'll be expecting any bad news. So they'll be like, okay, this is going to happen, so I don't want to hear it. So these are the things that comes into patient's mind. Then the fear of treatment being denied if they raise any questions or doubt. You can just consider that if you ask any unwanted questions, the other person will be like, he's asking so many questions. So how should I help him? Or like, why should I help him? So these kind of doubts comes in to the patient minds too. So they will be like, if I'm asking so much questions, they will be why should I help them? Kind of attitude from the doctor or the person who is sitting on to next. So there will be a small problem. A fear will be there, and the fear of losing control over emotions because they don't want to just break up in front of a new person. So that will be a barrier. Then stumped by the med speech because technical terms are very inappropriate things. Where during session 2, when I just mentioned the patient is having CP, one of you just asked me what is CP. So when I just answer like cerebral palsy, it was like if you are not aware of that thing, they'll be just like means the person will be like So it's a very big disease. So I have a concern like how could I overcome this or how will I do that? So we don't have to use that medical jargon words. We don't have to go through that med speech. We have to just think with the reality. Okay, just go with the reality. So these are the barriers related to patients. Then we as barriers, as a volunteer, as a physician, as a doctor, or as a nurse, as a social worker. So what are the barriers for us? First one will be concentrating only on physical tasks. So I'll be going through that point in the coming slide. Next one will be making assumptions or judgments. Like as I said, we will have to make that assumption or judgment at first. We have to treat them as a person only. Then the lack of training or experience, knowledge and skill. Because everyone is not perfect. Education is something, or the gathering of information is something that goes throughout your life. Because in palliative care too, you'll be going through so much work, so much experiences, so much cases, and everything. Every day is an experience. So the lack of training or experiences are a problem. So you have to first, before going into a patient's registration or to assess them, you have to be very clear what should I tell or what should I hear, like what should I do with them. So there will be a lack of training or experience. That kind of problem will be there. So you have to be very you have to be very keen onto that, and you have to take a big step to learn everything, and then only you can intervene. Then the appearance, because if you're going to a person and you are looking like you are in a dress what you use in your room or in other places will not be appropriate for everyone. So you have to be well dressed and well groomed. Then the facial expression of you, it is very important. So it will be a barrier for you. So you have to take care of it. Then avoid about being blamed or fear of worsening the situation. If you're not very expert in anything, don't say anything. It's not a problem. It's okay to be not okay. So before just giving some assumptions or um, any kind of what dialogues or some directions or something, you have to be very clear that this is okay, okay, or you have to refer to any other person. It's not a problem to ask with your senior or any experienced person. With that, the patient will get benefited. Okay, then the unfamiliar with language and what happens is everyone is not aware of every kind of language or anything. So you have to just make sure that the person is okay with your language and dialect. If not, then you can just ask for help with help of any other person. Okay, so these are the barriers for help. Then distancing tactics. So first one will be categorizing or labeling the patient. We will generalize everything like she is a breast cancer patient, he is a difficult patient. If you just say this to any other person, there will be a judgment. They will get a judgment like, okay, the senior social worker told me like he is very difficult to handle, or she is a cancer patient, breast cancer patient. So I have to deal with her like that. You don't have to categorize or label that patient. The next one will be paying selective attention to safe physical aspects that we were discussed in the previous slide. Like if the patient is asking about, Doctor, I'm so worried, I can't sleep early, I also have pain in the back. There is so much phrases there. Like I'm also worried, I can't sleep properly, I also have pain in the back. So there are three things that he's mentioning, and the doctor just asked him, "Tell me about the pain." So he's just asking about only the physical aspect. That is very safe, but it's not appropriate because you have to consider the whole problems. What is your worry? why are you not able to sleep properly? Then what happened in your back? What is the pain? So you have to ask like, you have to just you have to think of every aspect of that patient. Okay. Next one is never inquiring beyond the physical. How are you feeling? How are you being coping? So beyond physical, you have to ask whether what are the other concerns of that. Next one is using leading questions. Your pain is better, isn't it? So this will make the person think that you are only focused on the pain. This doesn't mean that you want to talk more about any other factors. So they will be like, you'll get only one answer. Your pain is better, isn't it? Yes. So that's there. So you are leading that person into that answer. That's it. So you don't have to use that. Next one will be using closed question like, do you have pain? There will be the answer will be like, no, I don't have pain. Or they will be, yes, I have pain. Then we can just go to the next stages like, okay, what's your pain scale? How are you taking medicines? If they said no, then we will just avoid that situation. So just don't use that closed question. Okay, just use open question, and this will lead to better communication. And then premature normalization. Like, don't worry, anybody in your position will say, no, not at all. No one will feel the same in that situation. Because every person is unique. You're just normalizing that situation because it's not right in any way. Because if I will be there in your situation, I'll be doing different things. Like if you consider this session would be taken by any of you, you will take it in a different manner or in a different way. So don't normalize prematurely. Okay. Then the next one will be steps to effective communication. So the first one will be build a relationship. That's very important. In building that relationship, only you can go for it. Then open the discussion because they will be hesitant to talk to you because they are very new to this setting, or they will be very new to palliative care. They don't know anything about palliative care, so they will be like they will be hesitant to talk. So open the discussion. Next, gather information. Information gathering is very important. With the opening discussion only, you can gather the information. Then understand the patient's perspective. Because if you just come across a cancer patient, you will be like, okay, there will be only pain, or otherwise they will be having any other symptoms. No, it's not same in everyone's case. So understand the patient's perspective first. Then share the information, what they needed. Like in the first stages, you know that everything is not to be shared. Something have to be just needed to be told in the later sessions. So share the information that is only needed. Then arrive at agreement on problems and plans. What happens is when you just consider a person and you just tell them like if a person asks you like, we need an oxygen concentrator and this is what I needed, what we needed, and you'll not be having that kind of concentrators and all in your place, and you'll get it by the help of some volunteers or donors, and all of a sudden you just give them a hope like okay, I'll give you within 2 days. But what happens when you don't get access to that oxygen concentrator? That hope or that trust is broken in there. So before that, before giving a proper answer to them, just think of what have to be done or what is on your hand. So then only you can just give them the right information. And just arrive at proper agreement, like this is what is going to happen, this is what we are going to do, and this is how it should be done, this is the plan. So then they will get the idea like, okay, this is going to happen, okay. So I'm accepting it. So I'm just not getting into the more terms. This will be done. Yeah, okay. So this is very important. And I have an agreement on problems and plans with them. Then close discussion sensitively. If you're having a tense day or you're having so much problems to deal with, just don't act like a person who's working in palliative care. Like, don't act like a person who's working in any other firms or that. Because this is palliative care and the patients are very sensitive. Every person is sensitive, and you have to close that discussion very sensitively. Like, okay, I have collected all the information. This is the plan for us, and you can just think of the better days. No problem. We'll talk to you very frequently, and if you need any help, just call us. This is our timing, and this time. So in this time, like in this time intervals, you can call us. No problem. We'll be there to help you. We'll be there to guide you. So this is how you can just close the discussion very sensitive. Next will be a few 4 or 5 slides only. So a good versus poor communication. Classify into four things like verbal do's, verbal don'ts, non-verbal do's, and non-verbal don'ts. Okay. So we will be going into verbal do's. Give the patient and family on the first visit. Introduce yourself because they don't have an idea like what is your designation, what is you're doing, and how can you guide them. So you have to just introduce yourself very properly. Like if in my case, I'll just say them, hello, please take a seat. Myself, I'm Sarath and a social officer. I'm not a doctor or a nurse, so I don't intervene in the physical aspect. I will just going through the psychological and social aspect. So this is the basic registration procedures. So I'll ask you some questions. You have to just answer. If you don't know the answer, no problem. So this will be the introduction of myself to them. And the next one will be ascertain the identity of those present. Because there will be doctors, nurses, volunteers will be there. So we have to just tell them this all the persons are from palliative care and these are there. The designations are this. Okay. Then use open-ended questions. Like you have to ask them, what are you doing now? What do you know about the diagnosis? How come you know about palliative care? You can use that open-ended questions. You don't have to use the closed questions. Are you okay now? When are you going back? So these kind of questions can be avoided, needed to be avoided. Next one will be encourage the patient to speak. If they are very okay with you, then you can go with that. If they are not okay, they're not opening it. You have to be keep patience, and then only they will open up. So encourage them to speak, and tell them we are here for the help. Okay. Then repeat important information back to the patient for confirmation, because in some cases what happens is they will say something and we'll write something else. So we have to just go through that important information and we have to repeat it back to them and we have to reconfirm it. Okay. Then use empathetic statements when appropriate. And don't say that it's okay or I have gone through that or something. We can just go through like we can do something. We can improve your quality of life. So how can we help to improve your quality of life? What is your exact problem right now? So we can use that kind of questions or statements to them. Then use pauses when appropriate, because if you talk very talkatively, like very speedily, they will not understand everything. So we have to just make a pause whenever appropriate. Then be honest what information to be given. Okay, and these informations are very important to be honest about the information to be given. Then verbal dots, like I said before, avoid medical jargon or terms, and then avoid inappropriate humor, because the patient will not be in a poor position to listen to that humor and to smile. So you have to avoid that inappropriate humor. Okay. If it is a kid, then you can make him laugh or something, no problem. If it is an adult or is a patient, then you have to respect it. So that's it. Then avoid ending the conversation suddenly, because you have a lot of things to do and you can't end that conversation very suddenly because there is a bus to catch or something. No, it's not. It's not to be done. Okay. Then avoid comparisons. Don't say that we have a same cancer patient here and they have gone through this and this and this. No, because they don't came here to be compared. So they are here for their purpose. So we don't have to compare with others. Then do not give premature reassurance or false assurance. Don't give them loose hopes. Just give them the correct information what they need. And do not ask leading questions, because on the first visit you don't have to enter into their personal space. So just don't lead anything. If they are willing, then you can just ask any other question. Then the non-verbal cues, as I said earlier, eye contact, pleasant or warm facial expression, leaning forward, respect the patient's need for personal space, smile and touch, use it carefully and appropriately. And last one will be listen. So I just discuss, we will discuss about it in the later one. Listen. Then non-verbal dogs. Do not stare at them. It's a normal thing. Do not stare at them, because if anyone stares at you, you will not be very confident to talk more. And do not break into the patient's comfort zone, because if they don't want to express everything with you, you don't have to be very like. So in the very first session, I want to collect all the information. This will not be happening. You will take more and more sessions or more and more and detailed assessments to get into their comfort zone and get into their more purpose. So do not break into that comfort zone. Then avoid unwelcome facial expressions. Use appropriate ones. And avoid indifferent or angry tone of voice, even if the patient is very indifferent or anger, because they have their own concern and they are going through a lot. And you have to just respect them, and you have to just understand that at the time of their assessment or something, they'll be going through severe pain. So they will be having so much anger. If you just give that anger back to them, they will be like, they will get very anxious and they will get very angry on you, and this will just broke the relationship or the rapport with them. Okay. Then the next one will be factors helping active listening. This is a small tip into this session. The first one will be nodding, and next one will be reflecting back what they are saying. You have to reflect back. Then lean forward and paraphrase. Okay, these are the 4 factors helping active listening. The next one is the important and the last one, because you don't have to listen to them passively. You have to listen to them very actively, because we are here for listening to their problems. Because they have so much problems, they have so much concerns, they have so much family related or health related or any kind of concerns and problems. So we have to listen to them very actively. Like we are here to help. We are here to guide you. So you have to be like that and then explore using open questions. With the help of listening, you'll get an idea like what can be done, what needed to be done, how far we can help, or if you want to just make goals that is long term or short term. So these kind of things can be done with the help of proper listening. So this is the end of our session. And I want to mention one word that is being depicted by none other than Padma Shri Dr. M.R. Rajagopal sir. It's easy to destroy somebody with few words. It's also easy to lift somebody up from the depths. So if they are willing to open up or if they want to communicate with you, just be with them and just listen to what they are saying. So then you will get an idea about everything and it will lead you to plan accordingly and get into a space where you can improve their quality of life. Not only the patient, their family members, and the surroundings also. So this is the end of my session. So if you have any doubts regarding anything, you can just ask me right now. Or this is a section for section for discussion.
Just want to ask one thing. So we basically discussed the general communication techniques which are common for doctors, nurses, social workers, and volunteers, right?
Yes, of course, ma'am.
Okay.
Because indeed, yeah.
How would supposing we were to say, since we are being trained for volunteers, would there be any difference, or it's the same application for everybody?
Actually, when you consider the doctor, the nurses, it will be different.
Okay.
And in the case of social workers and psychologists, this is also different.
Okay.
But when you consider this as a whole, like a volunteer and the team, the interdisciplinary, which includes the doctors, nurses, social workers, and psychologists, then the communication is same for everyone.
Okay.
But the purpose of it will differ from each one.
Sure, absolutely.
Because I just want to mention one thing that if the doctor is asking or if the doctor is communicating, he will be focusing on the physical aspects. And if the social worker or the psychologist is dealing with them, they will be thinking about the social and economical and psychological part.
Sure.
So what happens with the volunteer is you'll be having so much experience outside of our like outside of that physical and social things.
Yes,
You'll be having so much experience in life.
True.
So based on your experience, you can communicate with that person with a proper empathy. So that's why I think it's very important for you, for every person to communicate in a way that they will be like they have to be treated like that.
Okay. Sure.
Okay, so that's the thing.
We can show a video on communication. We have two videos on communication. I will share it right now.
Mr. Arun Kumar is suffering.
We have created this for education purpose for NHSRC. So it will be difficult to share these videos with you all. Yes, Satyasai, we can share it again. Wait a second. I think You can read it now.
So when communicating with the patients, what is and how does giving realistic hope differ than giving a false hope? Yeah, it's from Langniak E form. Okay. So when communicating with another person, like kind of with a patient, you have to be realistic. Means realistic hope means what is exactly going to happen. That's the first thing. And you don't have to like, when you consider a volunteer or a social worker or a psychologist, um, these questions can be answered with the help of a doctor because they only know what the physical condition is. So this is where that interdisciplinary team properly lies it. Because with the help of volunteers, psychologists, social workers, doctors, nurses, if everyone is having a meeting or if everyone is having a discussion about that patient's case, then you'll get an idea about how long or what are the next treatment methods or what can be done to them. So you'll get a clear idea about that. So then only you can give them the exact information about giving a realistic hope or a false hope. Don't ever give any hopes on the first sessions or first day itself because it will take a lot of time and then only you can just elaborate to them. Okay, so that's the first thing. And can you please show the first picture? Actually, we have just shown it. Then how do you answer when the patient says, why is God so good? This is another dilemma. It's like the spiritual phase. I think you all have gone in the psychosocial aspects of care session. So in that, I think the person have given all the details. I'll just mention one thing. In the spiritual case, it is not very commonly used still now because we need a lot of time to explore that spiritual aspect of a person because sometimes it will change according to like if you consider the person in a very bad situation, he will be like thinking about why this has happened to me because I have just prayed to God every time I didn't want anyone to suffer. I haven't done anything bad to anyone. So why this is happening to me? This kind of feelings come into every person. So for this, we have to explore more about them with more sessions. And in this phase, I think a social worker, a psychologist will be very very much into that dilemma because they will be dealing with such kind of interventions. So it will take a lot of time and effort to do that. So spiritual thing is to be considered. It is a long term one. And next one is it okay to discuss their medication as a volunteer? If you are expertise in medications, you can just tell them, no problem. But just keep this in mind. A doctor or a nurse, no, you can just consider the doctor only. A doctor is a person who is authorized to prescribe the medication. You can just discuss to them like what kind of medicines are you using right now? Is the pain is just going or is it still persisting? If you are the first person to visit that person, then you can ask them, no problem. But you don't like a doctor, we are not able to just prescribe or just give the medicines. So medications can be asked or discussed by a volunteer, but a health professional like a doctor is not into it. Okay. So any more questions? Anyone? So there is a feedback form for you, so you can just.
If there are no more questions, I think we can wind up today's session. Thank you, Mr. Sarath, for joining us. Thank you so much for that wonderful session on communication. As communication is one of the most important part in palliative care. Thank you so much. And we will be having 2 more sessions, one in home-based palliative care and another one in community and palliative care. So hope to see you all on the next section. Bye-bye.